Welcome to this deep dive. It's designed specifically for you, our listener, navigating the demanding world of nursing
It
studies.
definitely is demanding.
Yeah. And today we're tackling a topic that's incredibly important and really requires our utmost sensitivity: suicide prevention.
Hmm.
We know you're encountering just a huge amount of information, and our goal here is really to pull out the essential knowledge from Chapter 16, Suicide Prevention from Davis Advantage for Psychiatric Mental Health Nursing, 10th edition.
All right, to give you that clarity.
Exactly. Clarity and insights that are directly relevant to your future practice.
And this really is fundamental knowledge for anyone going into nursing.
Hmm.
Suicide is, it's a major public health concern right across the U.S.
It really is.
The statistics, they paint a pretty stark picture. It's a leading cause of death for people aged, 10 to 34?
Yeah, that young.
And its impact is felt much more heavily among veterans and certain marginalized communities. And maybe the most alarming thing, suicide rates actually saw a significant increase between 2000 and 2018.
That's worrying.
It is, and it just underscores the absolute vital role that, well-informed, prepared healthcare professionals like you listening will play in tackling this crisis.
Exactly. So, okay, what will this deep dive cover? We'll start by getting on the same page with the core terms: suicide itself, suicide risk assessment, and suicide prevention.
The basics.
Then we'll explore the different factors that can either sort of push someone towards risk or pull them away from it, the risk and protective factors.
Crucial distinction.
We'll also touch on some of the established theories that try to give us a framework for understanding suicidal behavior. And really importantly, we'll tackle and debunk some common myths about suicide that can actually be quite harmful.
Oh, definitely. Those myths are dangerous.
Yeah. And after that, we move into the practical side, how you actually apply this knowledge.
Right. So we'll discuss the key principles for doing a thorough suicide risk assessment. We'll even introduce you to some of the structured tools used in practice. Then we'll walk through the nursing process itself, how it applies when you're caring for a client who's having suicidal thoughts. From the assessment bit all the way through to specific interventions.
And then wrap up with special situations.
Exactly, like the really critical aspects of discharge planning.
Right.
And we'll briefly touch on some evidence-based therapies that have shown real promise.
Okay, great. Let's start then with those foundational definitions, just to make sure we're all clear. When we say suicide, suicide risk assessment, suicide prevention, what do we actually mean?
Okay, so suicide, in its simplest form, it's the intentional act of taking one's own life. Pretty straightforward definition, but obviously huge implications.
Right.
Suicide risk assessment, that's the comprehensive, systematic process healthcare professionals use. It's to evaluate if someone's having suicidal thoughts or behaviors and, figure out the level of immediate and ongoing risk.
Okay, a process.
It is. And then suicide prevention, that's the broader term. It covers all the strategies, the specific interventions we use to identify people at risk and then act to reduce that risk. These definitions, they're really the bedrock.
Got it. Bedrock established. So as future nurses, you need to know who might be at higher risk. Let's talk about those risk factors the notes mentioned.
The notes lay out several key ones. The presence of mental health conditions is a really significant contributor.
That makes sense.
Also, problems with substance use and the burden of chronic physical illnesses, those can really weigh on people. A lack of strong, reliable social support networks, a history of trauma or abuse, and critically, having access to lethal means, that's a big one, all these can increase vulnerability.
And demographics.
Demographically, yeah, the data shows individuals who are single or divorced and those who identify as white or American Indian Alaska Native have statistically shown higher risk. But, and this is so important to stress, these factors don't cause suicide directly. They just increase the probability, the likelihood. And notice, like you said, how many of these mental illness, substance abuse, trauma, they often lead to isolation, which ties back to that lack of social support. It's all interconnected.
That's a really good point about the interplay. Okay, flip side then. What helps protect people? What are the protective factors we should be looking to build up?
Right, the buffers.
Right.
Protective factors can really mitigate risk. Things like an individual's resilience, their ability to cope and bounce back from tough times.
Okay.
Strong problem-solving skills are another one. And having solid social support, feeling connected to others, that's huge.
Connection, yeah.
Also, cultural or religious beliefs that actively discourage suicide can be a really powerful protective force. And just having consistent, ongoing contact with medical and mental health services.
So keeping them engaged in care.
Exactly. Often, our interventions are really focused on bolstering these protective factors in people we identify as
Yep.
being at risk.
Okay, that makes sense. Now let's try to understand some of the underlying reasons or theories behind why someone might contemplate suicide. The notes bring up sociological, psychological, and biological angles. Let's start with the sociological one.
Okay, so these theories look at how society and our relationship with society can influence risk. There's egoistic suicide. The notes describe this as coming from a lack of social integration,
Meaning,
meaning feeling disconnected, isolated, not really belonging to a group or community, something really cut off.
okay.
Then there's altruistic suicide, which sounds a bit counterintuitive maybe. It stems from too much integration.
So much. How?
Well, where someone's identity is just so wrapped up in a group, they're willing to sacrifice their life for what they see as the group's benefit. The example given, like suicide bombers, illustrates that extreme form.
Wow. Okay.
And finally, there's anomic suicide. This happens during times of major social disruption, like a breakdown of norms, maybe widespread unemployment. People lose their sense of purpose, their place. Life feels unpredictable, leading to despair.
So it's really about that connection and social stability or lack thereof. Got it. Now, what about the psychological theories? What do they tell us about the internal experience?
Psychological theories shift the focus inward, to the individual's mind and feelings. Freud, for instance, suggested suicide could be aggression that gets turned inward onto the self.
Okay, aggression turned inward.
Yeah. The cognitive perspective, though, which is quite influential now, really emphasizes profound hopelessness and patterns of distorted thinking.
Hopelessness.
Exactly. Someone in that state might genuinely feel unable to see any positive future or any solution to their problems. It's like tunnel vision.
Right. And then the biological factors, what do those theories add?
Biological theories point to potential physiological contributors. One area that's been researched a lot is low levels of serotonin.
The neurotransmitter.
Yeah, the brain chemical involved in mood regulation. Low levels have been linked to increased risk. Plus, there's evidence suggesting a familial or genetic link. A family history of suicide might increase an individual's risk.
So it can run in families.
There seems to be a component, yes. But, and this is really crucial, these biological factors are complex. They're almost certainly not the sole cause. They likely interact in really intricate ways with all the psychological and social factors we've mentioned.
It's never just one thing, is it?
Rarely, if ever.
No.
It's usually a complex mix.
This multifaceted view is so important. Okay, let's pivot to something really critical for practice busting some of those myths about suicide.
Yes, absolutely essential. There's some really dangerous misconceptions out there.
Like what? What's a big one?
Okay, a really common one.
Yeah.
The idea that if someone talks about suicide, they won't actually do it. That they're just seeking attention.
You hear that a lot.
You do. But the fact, and this is vital for you as future nurses to really internalize, is that the vast majority of people who die by suicide have given warnings. They've expressed their intentions, often quite clearly.
So take everything seriously.
Every single expression, every hint, it needs to be taken extremely seriously and addressed right away.
That's such a critical point. Okay, what's another myth we need to absolutely debunk?
Another really harmful one, and unfortunately common, is believing that asking someone directly about suicide might somehow plant the idea in their head.
Or push them towards it.
Yeah, or make them more likely to attempt it. The reality is completely the opposite. Talking openly, directly about suicide actually reduces the risk.
How so?
It gives the person a chance, maybe the first chance they've had, to talk about overwhelming feelings, to feel heard, understood, connect with someone who cares. Direct questioning isn't just safe, it's a vital intervention. Don't be afraid to ask.
Yeah, okay, so we know what to look for, what myths to ignore, and that we shouldn't hesitate to ask directly. Let's shift now to how we actually assess someone, the suicide risk assessment process. What are the key principles?
Okay, principle number 1, use direct, unambiguous language. No euphemisms, no beating around the bush.
Just ask.
Just ask, clearly. Are you having thoughts of ending your life? Have you thought about how you might do that? Direct questions.
Okay, what else?
Second, remember that risk isn't static. It can go up and down, sometimes quickly. So assessment has to be an ongoing thing, not just a one-off checkbox.
Continuous monitoring.
Exactly. And third, try to get information from multiple sources if you can and if it's appropriate. Family, friends, caregivers, They might have seen things or heard things the person hasn't told you directly, with consent, of course.
Right. The notes also mention specific tools, SAFE-ET and CSSRS.
Yes. Tools like the SAFE-ET, that's suicide assessment, five-step evaluation, and triage, and the CSRS, the Columbia Suicide Severity Rating Scale, they provide a structured framework.
Like a checklist?
Sort of, but more comprehensive. They guide you to systematically check all the critical areas so you don't miss something important. They help you assess key elements like, well, intent. Do they really want to die?
Okay.
Needs. Do they have access to methods? Planning. How specific is the plan? How lethal? And critically, past attempts. A history of attempts is a major red flag for future risk.
So these tools help gather really specific information on thoughts, plans, history. Okay, now, how do we as nurses use all this in practice? Let's walk through the nursing process for a client with suicidal ideation.
Right. The nursing process gives us that systematic, patient-focused approach. First step, obviously, is assessment. We've talked a lot about this already.
Evaluating ideation, plan, intent, means.
Exactly. How often, how intense are the thoughts?
Yeah.
Any specific plan? How strong is the intent? Do they have the means available? And importantly, distinguishing between suicidal self-injury, where the aim is to die, and non-suicidal self-injury, which is often more about coping with intense emotions even though it's harmful.
That's a key distinction.
It is. You also assess their support systems, their current coping skills, what do they usually do when distressed, and their full psychiatric history, including past attempts or diagnoses.
Okay, comprehensive assessment done. Based on that, what kind of nursing diagnoses might we see?
You'll see several that are common. Risk for suicide is the obvious one, often linked to underlying feelings like hopelessness. But you might also see ineffective coping if they're struggling to manage stress. Hopelessness itself can be a diagnosis, or chronic low self-esteem, which can feed into vulnerability. These diagnoses then guide the care plan.
They point us towards what needs addressing. So what are the goals, the desired outcomes we're working towards?
The main goals, the outcomes we want to see are pretty clear. First and foremost, the patient will not harm themselves. They remain safe.
Safety first.
Always. Also, that they'll actively participate in developing a personal safety plan they can actually use when things get tough. And, importantly, that they begin to express some hope for the future, even just a little bit. That's a huge step.
Those are positive, tangible goals. So how do we help them get there? What are the specific nursing interventions? What do we do?
Okay, several key interventions. Number one, create and maintain a safe environment. This means meticulously checking for and removing anything potentially harmful, sharp objects, belts, cords, even excess medications.
Environmental safety scans.
Constantly. Then close observation. This can range from one-to-one constant supervision to checks every 15 minutes, sometimes at irregular intervals so the patient can't predict when you'll appear. The level depends on the assessed risk.
Okay. Observation. What else?
Encouraging them to talk. Verbalize their feelings. Create a space where they feel safe to express those overwhelming, maybe scary thoughts without feeling judged. Just listen. Accept their feelings non-judgmentally.
Being present and listening.
Hugely important. And developing that safety plan with the patient, collaboratively.
Yeah.
It's not a no-suicide contract. Those aren't really effective.
Right. Not a contract. What is it then?
It's a practical plan. It includes things like identifying their personal warning signs or triggers, what tells them they're heading into a bad place, then listing coping strategies they can use when those signs appear, and finally, names and numbers of supportive people and emergency contacts they can reach out to.
So it's concrete steps they can take.
Exactly. And throughout all this, using therapeutic communication, active listening, empathy, normalizing their feelings, letting them know it's okay to feel overwhelmed, exploring their thoughts gently, and, again, asking specifically and sensitively about suicide.
It sounds like a very active, engaged process. And then, of course, we need to keep checking if it's working. Evaluation.
Absolutely. Evaluation isn't the last step you do once, it's ongoing. Frequent reassessment is crucial. How is their risk level changing? Are they making progress towards those outcomes? Are they staying safe? Using the safety plan, showing any glimmers of hope, you constantly monitor and adjust the plan as needed.
Right. Now, the notes also mention special considerations, particularly around discharge when someone's leaving the hospital. What's key there?
Discharge planning for someone who's been suicidal needs meticulous attention. You absolutely have to ensure they have adequate support at home, who will be there, what's the plan?
Just send them out alone.
No. Developing that safety plan collaboratively, maybe involving family or others if the patient agrees, is vital. And reducing access to lethal means at home, The notes specifically mentioned firearms. That's a critical conversation to have. Removing means saves lives.
Definitely.
And finally, ensuring close, consistent follow-up. Often this means frequent outpatient appointments right after discharge, maybe even daily at first, to provide that ongoing support and monitoring.
That intensive follow-up seems key. And what about the families? People left behind after a suicide. The notes mentioned postvention.
Yeah, postvention. It's the support provided after suicide death to the survivor's family, friends, colleagues. It's incredibly important, but often overlooked.
What does it involve?
Survivors often grapple with intense grief, guilt, confusion, maybe anger. Postvention involves providing compassionate support, offering a safe space for them to talk about these complex feelings, helping them navigate the practical and emotional fallout. Sometimes it also involves looking at family dynamics that might be causing extra distress. It's about caring for those left behind.
That's really important work, too. Okay, finally, the notes briefly mention some evidence-based therapies. Can you give us a quick rundown?
Sure. Dialectical behavior therapy, DBT, is one. It's really good at teaching skills for managing intense emotions, handling relationships better, and being more mindful.
UBT skills.
Then there's cognitive behavior therapy, CBT. This focuses on identifying and changing those negative thought patterns and behaviors that feed into distress and suicidal thinking.
Changing the thinking.
Right. And CAMAS, collaborative assessment and management of suicidality, that's more of a framework, emphasizing a strong partnership between the clinician and the patient in figuring out and managing their suicidal risk together.
Collaborative, okay.
And one other thing the notes highlighted, there's good evidence now showing that just making early follow-up contact after someone leaves the hospital for suicidality significantly reduces their risk of trying again later. That proactive outreach matters.
Wow. Okay, this has been incredibly thorough. A really vital deep dive into suicide prevention. It's clear it's complex, requires understanding, compassion, and a really proactive nursing approach.
Absolutely. I think the key takeaways really are, understanding suicide risk is multifaceted. You absolutely have to assess directly and keep assessing. Open communication is powerful, and nursing interventions for safety and hope are crucial.
And using evidence-based methods.
Yes, and not forgetting postvention support for survivors. It's all part of a comprehensive response.
And for you listening as a future nurse, really getting your head around these concepts, developing these skills, it's invaluable. You're going to be right there on the front lines. Your ability to spot risk, talk effectively, intervene appropriately, it can genuinely make a life-saving difference.
It really can.
Yeah.
And maybe a final thought to leave you with, reflecting on everything we've discussed, all those risk factors, protective factors, how might you, in your own future practice, tailor your approach? How would you adapt your assessment and interventions for people from really diverse backgrounds, different life experiences, something to really think about as you continue your studies?